Good morning, good afternoon, good evening, depending on where you are. Thank you very much for coming to this press conference. My name is Tetsuya Mitsudomi. I'm the president of the WCLC and also the professor of surgery at the Kinda University, Osaka, Japan. This year, the Presidential Symposium, we saw a lot of the nice papers that covering from the screening to the stage 4 treatment with stage 4 disease, surgical treatment, things like that. And in addition, we have the paper about relapsed mesothelioma, which is another very difficult tumor in the thorax. And please, because of the time difference, we'd like to have the presentation presented from Australia first. So that after the 2 papers, we'd like to have the brief Q&A session so that the people from Australia can go to bed early. Then I do the rest of the papers. Our first presenter is Dr. Dean Fenner, a professor and a consultant in thoracic medical oncology and director of the Leicester Mesothelioma program based at the University of Leicester, University Hospitals of Leicester, NHS Trust. He's member of the WCLC Mesothelioma Task Force and the steering committee for the British Lung Foundation Mesothelioma Research Network. He's past president of the International Mesothelioma Interest Group, co-author of the UK PTS and European, which is ESMO or ERS mesothelioma treatment guidelines, and has served 2 terms on the ERTC board. So Dr. Penner, please.
Thank you very much indeed, Professor Tsudomi. So hopefully you can see my slides.
Yes.
Okay, excellent. Okay, what I'll do then is I've got a redacted summary of the presentation that I gave in the plenary, and what I'll try and do is highlight some of the key features of this study. So the first and most important thing to say about this is that this is a trial in the relapse setting where patients do not presently have a standard of care for mesothelioma. Now, mesothelioma is predominantly a disease that is not suitable for surgery. It's an advanced disease, and it's one in which chemotherapy, since around 2003, has been the standard of care. We've not seen any effective treatment in the relapse setting, despite a number of, in fact, I think 4 positive phase 3s in the first-line setting. So the objective here was to see whether or not a treatment could demonstrate superiority in the relapse setting, and using an anti-PD-1 inhibitor. This was based on very promising data, of course, across many other cancers, including lung cancer, but also monotherapy data with pembrolizumab being the very first in the the Keynote-28 study, and also 3 other, what has become 3 other trials of nivolumab monotherapy. So this trial was a appropriately powered randomized phase 3 2-to-1 randomization of nivolumab versus placebo. You can see here the numbers 2-to-1 versus 111 patients. Patients were administered treatment on a 2-weekly cycle, and the treatment could continue for up to a year, or unless there was progression, withdrawal, toxicity. And the study had a sample size target of 336, and we stopped at 332 due to COVID, the peaking. However, there was sufficient follow-up for us to be able to complete the trial and present the results. A little bit about the endpoints. Overall survival, progression-free survival, investigator reported. These are the co-primary endpoints. Secondary endpoints were progression-free survival determined by this tool, as modified RECIST 1.1, response rate, EQ5D, safety as well. So health economics were included within the analysis. And this, importantly, was an investigator-initiated study funded by Cancer Research UK and sponsored by the University of Southampton in the UK. So just to say that the most important take-home feature from this slide is the target overall survival. So we powered for a minimum of 291 survival events. I believe my statistician is on this call, so if we take any statistical questions, my colleague Gareth may be able to answer that with some statistical expertise. But we, in this particular paper, presented data on 232 survival events. So there is some maturing of the data that's required, but based on the top level results, as you'll see, we have a result that's statistically significant. And this is the top level result. So overall survival was significant for nivolumab. You can see sitting on top of the placebo here. Hazard ratio was 0.72. And I've highlighted the confidence here in the p-value of 0.018. This equated to 12-month survival percentage of almost 40% compared to 27% here in the placebo. And in absolute terms, median overall survival was 9.2 months versus 6.6 months. For progression-free survival, the other co-primary endpoint, the hazard ratio was 0.61. This was mature data. P-value was less than 0.001. This equated to a 12-month PFS of 14.5 months versus 4.9 months, and progression-free survival 3 over 1.8 for the placebo. Now, PD-L1 is certainly a predictor of efficacy for anti-PD-1 inhibitors in non-small cell lung cancer. Of course, is embedded in standard of care. But for mesothelioma, it's been really controversial, actually. Not only have we not seen a clear answer as to whether PD-L1 is predictive, but also we've seen quite a wide variation in the levels of expression of PD-L1. And I think this has been entirely down to the antibodies. But we can see here that PD-L1 measured using what could be defined as a standard test, the DACO22C3 clone of PD-L1 antibody. This showed no significant difference in PD-L1 positive patients for overall survival, 0.05 or 95, hazard ratio 0.0864 for the p-value, and similarly in PD-L negative, there was really no association of statistical significance, 0.115 p-value. So our conclusion was that PD-L1, at least in this setting, at least with this sample size, was not predictive or prognostic. In terms of safety, the highlighted figures here, I think, are in red. And the key message here is that nivolumab was safe. Remember, the control arm wasn't chemotherapy, it was placebo. 39% of patients had serious adverse events, and that contrasts with the 36%, slightly lower, for nivolumab. For overall adverse events greater than grade 3, we're looking at 45% for the nivolumab and 42% for the placebo. There were deaths. These were not necessarily treatment related, but in the serious AEs, this was 3.6% in the nivolumab arm and 5.3% in the placebo. So in summary, this trial was the first ever phase 3 in the relapse setting to meet its primary endpoint of improved survival. As I mentioned, we had co-primary endpoints as progression-free survival, and that too was positive. There was no evidence to support the use of PD-L1, at least with the DACO22C3 tumor proportion score, TPS, as a test. We saw significant benefit in the epithelioid subtype, and that may be something to discuss in a few moments. This effect in the non-epithelioid subtype, where we didn't see a statistically significant effect, may well be down to the sample size, which was small in that subset. And finally, nivolumab was safe, and for that reason, with its effectiveness, should be considered the standard treatment for patients with relapsed mesothelioma. Thank you very much.
Thank you very much, Dr. Fennell. And the discussion for this presentation will be Dr. Rina Hui, who is Clinical Professor of Medicine at the University of Sydney and the Crown Princess Mary Cancer Center. Westmead Hospital, Sydney, Australia. She serves as co-chair of the oncology block at the University of Sydney School of Medicine. She's principal investigator on phase 1 as well as landmark practice-changing clinical studies of immunotherapy and targeted therapies in thoracic oncology. Thank you very much for joining. It's very late. It's 1 a.m. in Sydney, I think. Dr. Huey, please.
Yes, I'm so sorry. I'm just trying to share my slides. Thank you very much, Dr. Mesothelioma. Right, okay. So thank you very much for giving me the opportunity to discuss about the CONFIRM study at this press conference. It is a long time coming to see a positive randomized phase 3 study with a checkpoint inhibitor in relapsed mesothelioma, as Professor Fennell actually mentioned earlier. This is my disclosure slide. Historically, there were very limited data on salvage treatment for relapsed mesothelioma. The options include retreatment with pemetrexate-based chemotherapy for those who achieved durable disease control from first-line chemotherapy, or single-agent chemotherapy, vinorelbine or gemcitabine, which would only provide overall survival of less than 6 months. Therefore, participation in clinical trials is encouraged. As you can see here, the large majority of immunotherapy studies in relapsed mesothelioma were small phase 1b and 2 studies. The only phase 3 study in relapsed mesothelioma unfortunately showed no difference in progression-free survival and overall survival when comparing pembrolizumab with single-agent chemotherapy. The CONFIRM study, which recruited 332 patients, added important, encouraging data on immunotherapy in the salvage setting. Particularly that patients were heavily pretreated. As you can see here, 2/3 of patients had received 2 or more lines of treatment. The study, as mentioned earlier, met co-primary endpoints of overall survival and progression-free survival with a hazard ratio of 0.72 and 0.61 respectively. PD-L1 as predictive biomarker in mesothelioma has been controversial. In the CONFIRM study, there was no evidence of PD-L1 being predictive. However, I want to point out that the proportion of PD-L1 positive disease was only 34%, much lower than most of the other studies. Also, only 70% of tumors were available for PD-L1 assessment. The authors concluded that significant clinical benefit was observed in the epithelioid subtype with hazard ratio of 0.71 and p-value of 0.021. We know that non-epithelioid is a more aggressive chemoresistant subtype, as indicated with a steep decline in the survival curve in the chemotherapy arm of this first-line study, CheckMate 743. Therefore, a lot of patients would not have made it to a subsequent line clinical trial, explaining why only 12% in the CONFIRM study. The first-line trial showed an improved benefit with nivolumab and ipilimumab in the non-epithelioid subtype, likely due to the association with high level of PD-L1. The sample size of the non-epithelioid subgroup in the CONFIRM study may be too small to detect a difference in outcome. I took the liberty to calculate the test for interaction, which was not significant with a p-value of 0.81. Taken together, I would not deny patients with non-epithelioid histology from considering nivolumab in the salvage setting. In the first-line setting, combination nivolumab and ipilimumab was superior to chemotherapy. We are awaiting the data from several first-line studies on combination chemotherapy with immunotherapy. In summary, I congratulate Dr. Fennell and his co-authors on the phase 3 CONFIRM study, having met both progression-free survival and overall survival endpoints. There was no clear predictive biomarker for patient selection, not PD-L1 or histology. In patients who had received platinum pemetrexate chemotherapy as first-line treatment, monotherapy nivolumab now can be considered as treatment option in the second-line setting or third-line setting after second-line chemotherapy. However, much still needs to be learned. As this study was placebo-controlled, unlike PROMISE, the question is whether nivolumab provides better outcome than second-line single-agent chemotherapy or second-line gemcitabine with a VEGFR inhibitor, ramucirumab. Would nivolumab and ipilimumab be superior to nivolumab in a salvage setting, as suggested in a non-comparable phase 2 study MAPS2? What can be considered as salvage treatment if nivolumab and ipilimumab has been used in the first-line setting? Platinum pemetrexate chemotherapy, or maybe gemcitabine and ramucirumab? We need to identify predictive biomarkers. We are also eagerly awaiting results from other first-line combination immunotherapy and chemotherapy to determine and develop other salvage treatments. With that, I thank you for your attention.
Thank you very much, Dr. Hui. The second paper is on the immunotherapy of lung cancer. So Dr. Michael Boyer is a clinical professor of medicine at the Chris O'Brien Lifehouse and the Central Clinical School of the University of Sydney, Australia. He is also the director of the Sydney Catalyst and member of the governing council, the Sydney Catalyst Executive Committee, and the clinical lead on the Sydney Catalyst flagship project, Enrich. So Dr. Boyer, please. Michael, you are muted.
Yep. There we go. Sorry,
Okay.
couldn't unmute myself. Thanks very much, and it's a pleasure to talk to you today about this presentation, which is for the Keynote 598 study, which is a randomized trial of pembrolizumab plus ipilimumab compared to pembrolizumab plus placebo for patients with metastatic non-small cell lung cancer and PD-L1 scores greater than 50%. They were my disclosures. Now, the design of the study is shown here. This is a trial of patients with stage 4 non-small cell lung cancer who are previously untreated and have good performance status, and importantly, a PD-L1 tumor proportion score of 50% or more. This is the first adequately powered trial that compares an anti-PD-1 monotherapy against the combination of anti-PD-1 and anti-CTLA-4. The study design shows that these patients were randomized to either receive pembrolizumab together with ipilimumab for up to a total of 2 years of treatment. That's 35 doses of pembrolizumab and 18 doses of ipilimumab at the doses shown here on the slide, or to pembrolizumab plus placebo. The primary endpoints of the study were overall survival and also progression-free survival as assessed by blinded independent central review. And the key secondary endpoints include response rate, duration of response, and safety. And just in terms of the statistics of the study, this study was intended to have 2 planned interim analyses and a final analysis. The first interim analysis occurred as directed by the protocol in September of last year, based on the number of events. And at that interim analysis, when the unblinded data were reviewed, the External Data Monitoring Committee requested futility boundaries. These were in place for the second interim analysis, but were applied at that first one. And the boundaries that are used are shown on this slide. The key results are shown here for the primary endpoint of overall survival. And what you can see here is that there is no difference in overall survival between the 2 study arms. So in blue is the pembro placebo arm, so pembrolizumab monotherapy. In green is the pembrolizumab ipilimumab arm. And you can see here that the median survivals are 21.9 for pembro monotherapy and 21.4 months for pembrolizumab ipilimumab, with a hazard ratio of 1.08 and a p-value of 0.74. And you can see also the 12-month survival rates. The futility boundaries that were set for this study were crossed by these results. And as a result, the study was stopped. Patients who were receiving ipilimumab and placebo ceased, and anybody having pembrolizumab could continue just with pembrolizumab monotherapy. The other primary endpoint was progression-free survival. And again, you see here that there was no difference in progression-free survival between the two study arms, with medians that are almost identical and a hazard ratio of 1.06, and again, a non-significant p-value. In terms of looking for subgroups of patients who might benefit, you can see here in the subgroup analysis that for all of the subgroups examined, the results are consistent with the overall trial results. So there's no subgroup here that has particular benefit or particular detriment. The results for all of these are the same as the result for the study itself. And I will point out before someone asks me that we have not looked yet at tumor mutation burden as a subgroup. So we don't know about that at this point. Where there was a difference, however, was in the adverse events. And very briefly, you can see here that whichever type of adverse event you look at, they were higher or more frequent in the pembrolizumab ipilimumab arm than in the pembro monotherapy arm. So all grade toxicity, high grade, grade 3 to 5 toxicity, serious adverse events leading to death, and adverse events leading to discontinuation. The consequence of this, in fact, was that there was less treatment given to the pembrolizumab ipilimumab arm because patients on that study arm dropped out because of adverse events. The most common adverse events you can see on the bottom right of the slide include the sort of things that we would normally expect with these combinations: pruritus, rash, and hypothyroidism, but there were also numbers of patients who had more significant things such as hypophysitis, colitis, and pneumonitis. So in summary, the addition of ipilimumab to pembrolizumab did not improve efficacy, and it did increase toxicity for first-line therapy for non-small cell lung cancer with high PD-L1 and no targetable mutations. The efficacy and the safety in the pembrolizumab ipilimumab arm and in the pembrolizumab monotherapy arm were as expected based on other prior studies. And because the futility criteria were met, ipilimumab and placebo were discontinued. Finally, this means that pembrolizumab monotherapy remains a standard of care first-line treatment for this group of patients. And to end, just to point out that if you want further details, this paper was published today simultaneously with the presentation. So thank you.
Thank you. Thank you very much. And Dr. Boyer's abstract was discussed by Dr. Yang Fan during the session today, but Dr. Fan is unavailable today. So these first two papers are now open for the questions. And here we have the Dr. Fenner's co-author, Dr. Gareth Griffiths too. So please ask any question to them. I mean, the first paper for the mesothelioma is a positive study, and the second study for the lung cancer was negative, but I think it's very important negative study. No questions at all? So you are, yes, please.
Caroline.
Oh, hi. Let's see, sorry. Let me see.
what my question was going to be to Dr. Boyer. Oh, so why was the cutoff the 50% TPS and not like 1%, for instance, in the trial design?
Well, because the 50% cutoff is the same cutoff that's been used in other trials looking at the group of patients with so-called high PD-L1. So this is not just positive PD-L1, it's high PD-L1. By comparison, for example, the Keynote-024 study used the same cutoff, and it's actually that study which was the first to establish pembrolizumab monotherapy as a treatment for that particular group. So the idea behind the study was really to take a group that already responded well and to see if it was possible to further enhance that response and that survival outcome. So
Okay.
by your question, I mean, the corollary to that is that we can't say anything about what would have happened had we looked at lower levels of PD-L1. That they weren't in this study.
And just a quick question. So is your explanation as to why it might be negative mainly due to the toxicity? You mentioned that there was less compliance. Do you think that's reasonable?
Look, that is one aspect of it, but I should point out that this sort of combination was also looked at in another study called Checkmate 227. And whilst I've pointed out the toxicity, in fact, the amount of treatment that people got in this study is almost identical. In fact, it's a little bit more than what they received in the Checkmate 227 study. So I don't think this was particularly unexpectedly bad. It behaved the way this sort of combination always behaves.
Got it. Thank you.
Okay, any other questions? If there's no more questions, I'd like to proceed. And Dr. Boyer, Dr. Huey, you may go to bed now.
Thank you very much.
Thank you so much.
Okay, so the next paper is on the lung cancer screening program in Taiwan. The author is Dr. Panchuyan, who is a chair and professor at the National Taiwan University College of Medicine. He was previously president of National Taiwan University. He was elected as member of Academia Sinica in 2006, the World Academy of Science in 2008, and the National Academy Inventors of USA in 2015. This year, he's a recipient of the ISCC Joseph W. Curran Prevention Early Detection Distinguished Service Award because of his contributions in translational research in precision cancer medicine and the implementation of lung cancer screening in never smokers, which significantly improved the survival of lung cancer patients in Taiwan. So Dr. Liang, please.
Thank you, Professor Mizudomi. I try to share my slides.
Mm-hmm.
Okay, it's really my great pleasure to share our national lung cancer screening program focused on never smoker. This is my disclosure. The incidence of lung cancer in never smoker is increasing globally, especially in Eastern Asia. Lung cancer is the leading killer in men and women in Taiwan. Never smoker, 53%, smoker, 47%. Most strikingly, female lung cancer, most of them are never smoker. 93% of them are never smoker. So never smoker lung cancer in Eastern Asia is a distinct disease. The genomic profile, the carcinogenesis, and the pattern of progression are different. We all know that low-dose CT screening focus on heavy smoker can reduce the lung cancer mortality. How about the lung cancer in never smoker? So we conduct the screening for lung cancer in never smoker with high risk, the so-called TALENT study, Taiwan Lung Cancer Screening in Never Smoker Trial. We performed the proteogenomic study and shows that lung cancer in never smoker is really a distinct disease. The genomic profile are different. We also discovered that alphabet signature is predominantly associated with early onset female lung cancer in never-smoker. We also identify the environmental carcinogen signature, which may associate with late-onset lung cancer, especially the nitropolycyclic aromatic hydrocarbon, which is common air pollutant. Another one is nitrosamine. It's very commonly used as a food preservatives in Eastern Asia. We also identify the proteomic biomarker, which can predict the outcome of early stage lung cancer patient. So we conduct a lung cancer screening trial focused on never-smoker with high risk. The inclusion criteria, 55 to 75 years old, never-smoker or light smoker. They have one of the following risks: family history of lung cancer, environmental tobacco smoking history, chronic lung disease, high cooking index, or cooking without using ventilation. The chest X-ray negative, then we recruit the subject. For the low-dose CT screening, we also take the blood, urine for biomarker study, and they also receive the questionnaires. We totally recruit 12,011 subjects, and half of them had family history. This is the first round lung cancer detection rate of the TERRAN study. As you can see here, the first round lung cancer detection rate is 2.6%, which is higher than National Lung Screening Trial, NARST, 1.1%, and Nelson, 0.9%. The invasive lung cancer is 2.1%, multiple primary lung cancer is 17.9%. We define the low-dose CT positive is the ground glass opacity larger than 5 millimeter, or solid or part-solid lesion larger than 6 millimeter. So the low-dose CT positive rate is 17.4%, and invasive procedure 3.4%. In lung cancer patient confirmed, 96.5% of them are stage 0 to 1. And most of them, the lesion is ground glass opacity. The prevalence of lung cancer with or without family history is 3.2% versus 2.0%. So if we look at the prevalence of lung cancer in different subpopulations, you can find that those with family history had higher risk as compared with those without family history of lung cancer. Among the family history, the first-degree family are most important, especially the mother, brother, and sisters. The other risk factors, including the passive smoking, chronic lung disease, high cooking index, or cooking without ventilation, are less significant. If you look at the family member with lung cancer, as you can see here, the more first-degree relatives with lung cancer, the higher the likelihood of lung cancer detect among the screened individual. So this is the summary. Lung cancer in never-smoker is a global rising threat. The pathogenesis and method of screening may be different. The TERRAN study shows that the lung cancer detection rate is the first round 2.6% higher than NARST and Nelson. Then most importantly, lung cancer detected in the TERRAN first round, 96.5% are stage 0 to stage 1. Multiple primary lung cancer, 17.9%. First-degree family history of lung cancer may increase the risk of lung cancer. Low-dose CT screening for never-smoker with high risk may be feasible. Thanks for your attention.
Thank you very much. And Dr. Yan's paper is supposed to be discussed by Dr. Pastorino, but I don't see his name now. Dr. Pastorino? Okay, so if he is not here, then I'd like to proceed. The next two papers is a perioperative therapy of lung cancer. The first one is a post-operative adjuvant chemotherapy, and this will be presented by Professor Novello, who is presently Professor of Medical Oncology at the Department of Oncology at the University of Turin, Italy. Professor Novello's main area of research is based on the aspects of basic research and applied clinical research concerning bronchogenic carcinoma. She is a previous member of the ISAC Board of Directors. So Sylvia, please.
Thank you, Tetsuya. I will try to share my screen, but there is a message telling me that I'm unable or I'm not allowed to share the slides. Can you give me the permission?
Yes, Chris, can you make Dr. Novello an organizer, please?
Thanks a lot.
Yes, stand by.
Yeah.
Chris, would you like me to just bring up the slides? Is that easier?
No, she's co-host now. I just said it took a
Okay.
minute to find her. That's all.
Got it. Thank you.
You should be able to run that now, Dr. Novello. Apologize.
Thank you so much. Yeah, no problem. Thanks a lot. So thank you very much for giving me the opportunity to present again the results of Ithaca trial that is an international tailored chemotherapy adjuvant phase 3 study on pharmacogenomic driven versus standard of care in completely resected stage 2 and 3A non-small cell lung cancer. And I have already presented this data on behalf of all the Ithaca investigators. Despite its modest advantage in terms of survival, cisplatin chemotherapy is considered and is the standard of care for completely resected non-small cell lung cancer patient. But we strongly believe that there is still a need to better identify those patients to really benefit from this approach in terms of outcomes and also in terms of safety. And this is the reason why we designed this phase 3 trial, looking at the role of pharmacogenomic and focusing on ERCC1 and thymidylate synthase based on previously reported and published data on these two biomarkers, and specifically using TS because it is part of our research as group of research at the University of Torino. But Ithaca is an initiated investigator trial conducted in 31 centers in Italy, Germany, and one in Poland, randomizing completely resected non-small cell lung cancer with stage 2 and 3 with an ECOG performance status 0 or 1 to receive a chemotherapy within 5 to 8 weeks after the resection. And the randomization was based on real-time PCR level of ERCC1 and TS. And we decided to have a randomization looking at the high level or low level of these two biomarkers, identifying 4 profiles. And for each profile, there was a randomization to receive the standard of care that you can see here represented in green, or the tailored arm here represented in orange. But at the end, the comparison, so the main and the principal endpoint of the trial is to compare all the pharmacogenomic driven arms versus all the standard of care arms grouped together. The randomization was done using smoking habit and the stage as a stratification factor. One important point is that having 21% of the patient randomized, the trial was amended, and this is maybe the first large adjuvant randomized trial, including the latest ISSC staging system. This is the flow of the study. You can see the number of the patient allocated to the tailored arm and the patient randomized in the control arm. I did not include the patient characteristics for reason of time, but you can trust me, they were well balanced between the two arms. In the vast majority of the cases, the resection was a lobectomy. 2/3 of the patient with a stage 2 disease, 11% of never smokers. And this is the primary endpoint. So the primary endpoint was the overall survival with a median follow-up time of 28 months. The hazard ratio is 0.76 with a median overall survival time for the tailored arm equal to 96.4 and the median overall survival time for the control arm equal to 83.5%. And among the secondary endpoint, the recurrence-free survival with the same median follow-up time and 260 events, the hazard ratio is 0.94, and the median recurrence-free survival for the tailored arm is 64.4 versus 41.5 months in the control arm. One important point that is again in one of the secondary endpoints is the safety profile. We have already presented some preliminary results during the World Lung Cancer Conference in 2015, and there is an advantage. There is a decrease in terms of toxicity, mainly in terms of hematological toxicity in the tailored arms, and this is, I believe, one of the important results when we are talking about pharmacogenomic driven trial design, where the endpoints are for sure the efficacy together with the safety. So our conclusion, the adjuvant chemotherapy customization based on the primary tumor tissue and based on the mRNA level of ERCC1 and TS did not significantly improve OS and recurrence-free survival. But as you have seen, there was a non-statistically significant trend for overall survival favoring the customized arm. Unfortunately, when the final analysis was performed, the study was underpowered and we were only able to reach 46% of the expected event. But keeping the point of the hazard ratio in the trial design, the hazard ratio estimated and the expected 336 events collected, at that point, the hazard ratio would be between 0.61 and 0.94, therefore significant. It is important to underline that the treatment customization significantly improved the toxicity profile without compromising the efficacy. So we believe that more comprehensive diagnostic technique will be needed to tailor adjuvant chemotherapy, maybe pulling together these results with the future results coming from the adjuvant trial with or without immunotherapy in completely resected non-small cell lung cancer. Thank you so much for your attention.
Thank you very much. And Dr. Novello's paper is discussed by Dr. Toyoka, but next paper is also about the predictive therapy. So the two papers will be discussed by Dr. Toyoka after the next presentation. So the next presenter is Dr. Jay Lee, who is Associate Professor of Surgery at the David Geffen School of Medicine at UCLA and Chief of the Division of Thoracic Surgery at UCLA Health, Los Angeles, California. He is also a surgical director of the Thoracic Oncology Program at Johnson Comprehensive Cancer Center and the surgical director of the Center for Esophageal Disorders at UCLA Health. So, Dr. Lee, please.
Thank you very much for giving me the opportunity to present today surgical and clinical outcomes with neoadjuvant atezolizumab in resectable stages 1B to 3B non-small cell lung cancer, the LCMC3 trial primary analysis. The LCMC3 study is unique in that it is the largest monotherapy immune checkpoint inhibition study in resectable non-small cell lung cancer patients. Equally important was the aggressive collection of biospecimens that included tumor, lymph nodes, and blood. Patients received 2 cycles of atezolizumab preoperatively, followed by surgical resection. Postoperatively, patients were followed with a surveillance plan and had the option to receive adjuvant atezo for up to 12 months. The primary endpoint was major pathologic response. 43% of patients had downstaging following neoadjuvant atezolizumab. Comparatively, 19% of patients had upstaging. The dark blue bars represent the post-treatment pathologic stage, and the turquoise bars represent the pre-treatment clinical stage. And one can see that there's a shift and increase in the dark blue bars consistent with downstaging following neoadjuvant atezolizumab. Our study distinguishes itself from historical neoadjuvant chemotherapy trials in that surgery was performed within a tight protocol window, and surgery was allowed a lot earlier from the completion of neoadjuvant atezolizumab. So what do I mean by this? 88% of patients had surgery within a tight 20-day window allowable for surgery. 12% of patients had surgery outside of the protocol window, and the median time outside of the protocol window was an additional 8 days. Of the patients that required surgery beyond the protocol window, the majority of the time, the reasons were not related to the treatment itself. The median time from the end of cycle 2 to surgery was 22 days. In the LCMC3 study, patients were allowed to go to surgery as early as 8 days, followed by a 20-day protocol window. In comparison, historical neoadjuvant chemotherapy trials often had surgical windows that were much later from the completion of chemotherapy, usually about 3 weeks or 21 days out from completion of neoadjuvant chemotherapy. And the allowable window was often stretched wider, up as high as 56 days from completion of neoadjuvant chemotherapy. Our study demonstrated that more than half the patients underwent resection with a minimally invasive approach utilizing a VATS or robotic operation. And remarkably, only 15% of patients required conversion to thoracotomy. The extent of resection in the majority of patients was an anatomic oncologic operation, whereby 79% of patients underwent a lobectomy operation. This resulted in a completeness of resection with an R0 resection rate of 92%. Our findings are at least comparable, if not superior, to historical neoadjuvant chemotherapy studies. The LCMC3 study demonstrated that the intraoperative complication rates were rare, that the length of hospitalization was expected and comparable to historical information, and the mortality rates were superior to expected outcome data historically. The intraoperative complication rates for bronchial and vascular complications were rare, and all complications were successfully repaired in the same operation. The length of hospitalization had a median of 7.5 days. In comparison to the Society of Thoracic Surgeons Historica data, the mean length of stay was 7.4 days. The mortality following surgery within the first 30 days was 0.6% and was due to one patient that had a sudden death that occurred and was felt to be not related to the treatment. From 30 to 90 days following surgery, there was one additional mortality due to a treatment-related pneumonitis. The exploratory endpoints of DFS and OS were also quite favorable. The dark blue curves represent the stage 1 and 2 patients, and the stage 3 patients represent the red bars, the red lines. The 1 year and 1.5 year OS survivals were quite favorable. At 1 year, for stages 1 and 2, the OS survival was 92%, and for stage 3, it was 95%. While there's limitations to comparing the current trial results to historical information, the dark gray curves represent the IA-SLC data and corresponding expected overall survival presented in a stage-dependent fashion here. The overall survival for both cohorts in the LCMC3 survival in the LCMC3 cohorts were superior and to the expected overall survival historically. These findings suggest that there may be an overall survival advantage following neoadjuvant atezolizumab. In conclusion, the LCMC3 study successfully met its primary endpoint of achieving major pathologic response in 21% of patients and a pathologic complete response rate of 7%. Neoadjuvant atezo as monotherapy was well tolerated with no new safety signals, and resection was performed with low perioperative morbidity and mortality, usually within a narrow protocol window with a short time frame to surgery from completion of atezolizumab, and with a corresponding high R0 complete resection rates. This study provides additional clinical evidence for the ongoing phase 3 trial of Empower 30 with combined atezolizumab and platinum-based chemotherapy. Thank you.
Thank you very much. And Dr. Novello's paper and Dr. Lee's paper will be discussed by Dr. Shinichi Toyoka. Dr. Toyoka is a professor of general thoracic breast and endocrinological surgery at the Graduate School of Medicine, Dentistry and Pharmaceutical Sciences, Okayama University. Dr. Toyoka is a previous recipient of the WCLC Young Investigators Award and is an associate editor for the Journal of Thoracic Oncology. So Dr. Toyoka, please.
It's my great honor to be a discussant, Dr. Lee's slide presentation. This is my disclosure. Okay, I'm Shinichi Toyoka, thoracic surgery of Okayama University, as Dr. Mitsudomi introduced. The purpose of neoadjuvant therapy is to facilitate resection by reducing the cancer burden in the primary site and regional lymph node, and to eradicate possible micrometastasis. The strategy shown in the right side of this slide with illustration a possible pattern of ICI usage in neoadjuvant therapy. ICI alone, combination of ICI and chemo, the combination of ICI, chemo, and radiation. In LCMC3 study, the large number 181 patients with stage 1B to 3 were enrolled. Atezolizumab was administered with 2 cycles. Measure pathological response was primary endpoint. And feasibility especially surgical point of view, is one of the important secondary endpoints. Overall survival and disease-free survival and biomarker were exploratory endpoint. Among 181 patients, primary efficacy population was 144 cases, and among them, 21% showed major pathological response, and 7% showed pathological CR, with which this study met the primary endpoint. Regarding feasibility, on the whole, it is acceptable, including the compression ratio of primary planned minimally invasive surgery. This fact suggests that the neoadjuvant therapy with ICI may not affect the difficulty of surgical procedure. This is mini review of neoadjuvant ICI with nivolumab and atezolizumab from the viewpoint of ICI with or without chemotherapy. Comparing these two strategies, as expected, the combination showed high rate of pathological CR like NADIM study, which indicates the combination therapy is stronger treatment than ICI alone. Left panel in this slide shows disease-free survival of primary efficacy population, although it is immature data regarding survival. 1.5-year survival of stage 3 patient was 85%. As a reference, please see the right panel. 2 years PFS of the DEEM trial. It is intended to treat population was 77.1%. Regarding adverse effect, it was lower in single ICI group compared with combination of ICI and chemo. The relationship of treatment strengths and toxicity is shown with illustration. Based on the survival data of LCMC3 studies shown in the left row table, there were no differences in survival in stage 1 to 2 and 3. Thus, I think that the single ICI as neoadjuvant therapy can be used for early stage and patient with poor PS. By contrast, ICI and chemo combination should be for the patient with more advanced but resectable cases, like locally advanced cases. This is a summary. Neoadjuvant atezolizumab monotherapy is effective, well-tolerated, and surgically acceptable. ICI monotherapy was combined therapy as neoadjuvant therapy may have their own target population based on disease stage and the patient condition, if we considered it. The secondary analysis for predictive biomarker based on clinical specimens collected in the course of this trial is expecting. Thank you for your attention.
Thank you very much. And if you have any comments on the Dr. Novello's paper?
Yes, I'm very concerned regarding ERCC1 quantification because that they use qPCR to detect ERCC1, but it is very I think it's very difficult to detect effect specific isoform that is associated with real function with ERCC1. So I want to confirm what happened or what kind of improvement we have to do to quantification with ERCC1.
Okay. Okay, maybe we ask Dr. Novello after the Dr. Bob Lee's presentation. So the last paper is about the targeted therapy for the KRAS mutations. And as you may know, the KRAS mutation is the oldest oncogene, and the therapy for specific therapy for the KRAS mutation has been long waited. So Dr. Bob Lee is a physician ambassador to China and the Asia Pacific at the Bobst International Center and the co-director of the thoracic liquid biopsy program at Memorial Sloan Kettering Cancer Center, New York City. He has led numerous trials involving the targeting KRAS and HER2. His research was discussed during the session by Dr. Panchuyan, but he's not available today. So Dr. Babri, please.
Thank you, Dr. Mitsudomi, for the introduction. I will just now give you the high-level results for CodeBreak 100, the registrational phase 2 trial of sotorasib in KRAS G12C mutated non-small cell lung cancer. These are my disclosures. This is a non-randomized, open-label, single-arm study in patients with advanced stage KRAS G12C mutant non-small cell lung cancer. Sotorasib was given once a day orally at 960 milligrams daily. The primary endpoint was overall response rate by RECIST 1.1, and it was done by the blinded independent central radiology review. We also looked at secondary endpoints of duration of response, disease control rate, the progression-free survival, overall survival, and also some exploratory biomarker analysis looking at PD-L1 expression and co-mutational signatures. We enrolled a total of 126 patients across 11 countries. This was an international effort spanning North America, Europe, and Asia Pacific. As you can see from the table of patient characteristics, this is largely a heavily pretreated population, up to 3 prior lines of therapy. And most patients had prior platinum-based chemotherapy or PD-1, PD-L1 inhibitors with immunotherapy, and 81% had progression on both types of therapies. The median follow-up time was 12.2 months at the data cutoff last month, December 2020. So this is the primary endpoint. The confirmed overall response rate was 37.1%, including 3 complete responses and 43 partial responses. This is the waterfall plot. As you can see, 81% of patients had some tumor shrinkage of any magnitude, and the median percent of tumor shrinkage was 60%, and that also included the 3 complete responses. So this is suggestive of the depth of response to sotorasib. This is the swimmers plot for the 46 confirmed responses, and you can see from the green diamonds towards the left that indicate the first response. About 72% of the responders actually had an objective response by the first CT scan at week 6. And the median time to objective response was fairly rapid at 1.4 months. You can see from the red portion of each row that indicate the duration of response, with the arrows indicating that the patients have ongoing response without progression. The median duration of response was 10 months, and 43% of those responders remained on treatment without progression at the data cutoff last month. And further data on the durability of treatment benefit, the progression-free survival had a median of 6.8 months, consistent with phase 1 results. The treatment-related adverse events were acceptable, no surprises compared to the phase 1 results. They were largely grade 1 or 2 with no treatment-related deaths. The common toxicities were mainly gastrointestinal, including diarrhea, nausea, elevated liver enzymes, but mostly treatable, reversible with supportive measures or dose modification. 22% of patients needed a dose modification, and 7.1% of patients had to stop the treatment because of toxicity, but those toxicities were reversible, and generally, overall, it was manageable. There was one patient who had a grade 4 treatment-related toxicity who reported pneumonia and dyspnea, and we, in the end, reported as drug-induced, possible drug-induced pneumonitis. So, in conclusion, the sotorasib is the first-in-class KRAS G12C inhibitor, which demonstrated rapid, deep, and durable responses in patients with advanced KRAS G12C mutant non-small cell lung cancers. The overall response rate of 37.1%, median duration of response of 10 months, and a median progression-free survival of 6.8 months, all validated previous phase 1 results. And these results are clinically meaningful for these patients, which represent a refractory cancer population of unmet need. Sotorasib was generally well tolerated and with acceptable safety profile, and the tumor response was also seen across a range of biomarker subgroups by PD-L1 expression, as well as STK11 mutation. Sotorasib received breakthrough therapy designation from the United States FDA just last month. And I'm pleased to report that the regulatory filings actually have been submitted to the US FDA, as well as the European Medicines Agency. There's ongoing dialogue and submission with other regulatory agencies in other countries, including the UK, including China, Australia, Canada, Brazil, and many others. We just heard yesterday there was a breakthrough therapy designation granted by the China National Medical Products Administration as well, which is encouraging. And phase 3 confirmatory CodeBreak 200 trial, which is looking at sotorasib versus second-line docetaxel, is currently enrolling. So with that, thank you for listening.
Thank you very much. So now the 4 papers are open for the question. But before that, I'd like to ask the comments from Dr. Novello about Dr. Toyoka's question. Dr. Novello, you're not here?
Yes, sorry, I'm here. Sorry, Tetsuya. Yeah. Well, the evaluation, as he comment, was done, and the randomization was based on a real-time PCR. So we are detecting in the reality the entire gene. And in this way, we were trying to avoid the issue due to the different isoform of ERCC1, as well underlined and demonstrated by the French group and by the publication of Friboulet in New England Journal of Medicine. Together with this, among the secondary endpoint, in any case, there is the cross-evaluation of immunohistochemistry, so the expression of protein of ERCC1 and TS, but this is still an ongoing analysis, and this will be presented soon. And it was not the evaluation guiding the randomization of our patient. Regarding the cutoff, these were based on our previous experience. So the cutoff were established on previous experience on the same subgroup of patients. So again, completely resected non-small cell lung cancer, consecutively analyzed before starting with the Ithaca trial. So the cutoff to define those high and low level were based on our previous pilot trial in the same category of the patient. I don't know if I answered to the observation or the doubt raised by the discussant, but these were our design.
Okay, thank you. Okay, so please ask any questions to any speakers.
Just a note, please, for press, please introduce yourself and tell us where you're writing from too. That would be very helpful to the speakers. Thank you.
Oh, okay, this is Lynn Peterson from Trends in Medicine. For Dr. Lee, please. So if this drug were approved, are there any barriers to its adoption, or how rapidly or broadly do you think it would be adopted?
Hi, this is Bob Lee. I assume this was addressed to me instead of Jay Lee, so I'll take this.
I did mean that, yes, thank you.
So sotorasib, yes, we have to hope and assume that it will be approved at some point. Yes, there are regulatory, there are still barriers. For example, usually it gets approved by the United States FDA first. So in terms of getting it to patients, I mean, that's a matter of just getting pharmacy, getting the insurance on board, getting the treatment guidelines. That usually is pretty quick in the United States. Now, in terms of getting the drugs to other jurisdictions, that's a little bit more complicated, and that the EMA has a separate process that's quite independent, and there's also the payment issues as well. And even in the United States, there are it's quite complex in terms of payment for drugs. It's usually covered by insurance programs. You know, that sort of really depends on your coverage and so forth. There's a lot of health economics barriers indeed. And then the other countries in UK, in China, in Australia, I think that will certainly take time. And what about the gap between an approval and the availability or the you know, sort of insurance coverage? And there may need to be some programs, compassionate use, expanded access use, and certain means to get patients to treatment. So I think we all have to work together.
I'm sorry, I wasn't clear. I was assuming that once it's approved, I'm talking about adoption by doctors. Is this data compelling enough that this is going to be given to a significant number of patients? I mean, talk a little bit about if you have the approval and you have the insurance coverage, where is this going to fit?
Yeah, so this is certainly a job for all of us. I personally would be very comfortable, once approved, prescribe this to my patients in the second-line setting based on the clinical trial evidence. And for widespread adoption, that requires a lot more CME, so continuous medical education for both academic and community oncologists. And the first step is, I think, starting now, is to get KRAS mutation testing in all patients with non-small cell lung cancers. And that needs to be done routine. So, because for 40 years, we've thought KRAS as undruggable. So there's a school of thought that there's no point testing because you can't do anything about it. But that's, for the first time, changed. So I think routine KRAS mutation testing is a good start. So you can at least identify those mutations in patients' tumors. Then you open up the opportunity for access to therapy. So that's a starting point, starting now. But I think I'm pretty confident that the thoracic oncology community is pretty quick to adopt new innovation. And I think this is going to be widespread routine pretty quickly.
Yeah, I agree. So could you explain a little bit about the G12C? So someone do not understand the G12C, right?
Yes, thank you. This has been certainly a tough nut to crack for for almost 40 years since discovery. There's been numerous attempts to crack KRAS. The difficulty is that the KRAS protein is like, it's round, it's like a ball, it's very smooth, and there are no pockets or clefts that are good for drug binding. So this contrasts with EGFR, ALK, and other oncoproteins where you can fit you can use a lock and key approach just to lock it up. There is no structural opportunity for that. So for 40 years, it's just impossible to drug. It's like you're catching a tennis ball with the key and it bounces off you. So, and efforts at downstream inhibition below KRAS to shut it down with RAF inhibition, MEK inhibition, ERK inhibition have all failed largely because of narrow therapeutic index. If you dose too high, it's too toxic. Human beings cannot tolerate that level of inhibition. So this seminal breakthrough came actually in 2013 when credit to Dr. Shaukat and his lab at UCSF, where they made the seminal discovery published in Nature 2013, where they discovered, contrary to dogmatic belief, KRAS mutations actually are not constitutively active. They are active mostly, but they also oscillate to an GDP-bound inactive state, but they prefer the GTP-bound active state. But they go sort of on and off, they wake up, they go to sleep, and when they get to that inactive state, there is a structural change, and in that switch 2 pocket, there opens up a little pocket in that switch 2 region, and that little pocket gives you that vulnerability and opportunity for drug binding. So this was further developed. The mechanism was published in 2016 by my colleagues, Piro Lito, Neil Rosen, and others at Memorial Sloan Kettering. This was a paper in Science in 2016, and where we described this trapping mechanism where you fit a drug into that pocket in the GDP-bound inactive state, thus trapping it, preventing the KRAS protein from waking up. So you keep it at sleep and you lock it up. So you're trapping it, and that shuts down oncogenesis signaling, and therefore the tumor stops growing. And sotorasib precisely uses this trapping mechanism to shut down KRAS G12C. This is very specific for the G12C allele of KRAS because of that structural biology. And that's the basis, scientific basis for this advance.
So G2C is glycine to cysteine, right? Cysteine.
Yeah, it's a glycine to cysteine substitution, and with that, it opens up that
particular mutation. Okay, any questions? Other questions? Yes, please.
Hi. Yeah, Caroline Helwick, the ASCO Post. For Dr. Novello, you mentioned that overall survival seemed premature. It was maybe not based on enough events. So I wonder if you're going to follow these patients further and may anticipate that you would see a survival benefit.
So the problem is that in the last year of follow-up, no major changes were observed within the new events. This is the reason why we decided, together with the statistical institution who is following us and is making with us the analysis, to present the data, because the perception was not having very soon new events or a larger number of events. But in any case, with Walter Torri, we made the hypothesis to reach, following the same shape of the curve, so to reach at a certain points those 336 events. And in fact, at that point, the results seems to be significant. So the answer to your question is yes, we will continue to follow up those patients, take into account that 2/3 of the population were stage 2. So not surprising to have such kind of follow-up and data. But anyway, we were surprised not having too much events in our population despite the long follow-up. Thank you for your question.
Okay, thank you.
Yes, Dr. Toyoka.
Okay, I have a question to Dr. Lee regarding our LCMC3 study. From the viewpoint of surgery, 15% converted to thoracotomy. Am I right?
Yes.
So can you explain the reason for that? For example, this is within expectation, or it's accidentally, or it is supposed to be associated with ICI treatment?
Yeah, so this is difficult to follow because following neoadjuvant immune checkpoint inhibition, there has been reports from the smaller phase 2 studies of increased perihilar or lobar fibrosis and reported conversion rates for surgery to thoracotomy have been as high as 45–50% in the initial smaller studies. In LCMC3, we did not track that information prospectively. We did do a post hoc analysis, and surgeons did report having increased perihilar fibrosis, but it did not seem to impact very much the conduct of the operation overall. And it's difficult to assign if that level of fibrosis was due to the immune checkpoint inhibitor, or was it inherent to like a desmoplastic reaction to the tumor. So at the end of the day, it's difficult to attribute it to the atezolizumab. But at least in LCMC3, it did not seem to impact the conduct of the surgery in terms of intraoperative complications, and the conversion rates seem very comparable and expected to historical surgical data on conversions.
Okay, thank you.
So Dr. Yan, so you found that family history is very much associated with the risk of the lung cancer in non-smokers. So do you have any hypothesis, or do you have any candidate in which is responsible for the family history?
Yes, actually, we do identify some candidates. Among them, the YAP1, YAP1, the YAP1 oncogene may play a very important role, especially in family cluster non-smoker lung cancer history, non-smoker lung cancer family. They tend to have a YAP1 gene mutation. We also identify some SNPs and some genetically susceptible risk genes associated with never-smoker lung cancer. We are now carrying out this study, try to develop a risk score, polygenic risk score, which may be helpful for us to develop, to identify the high-risk population that can benefit from low-dose CD screening.
That's very interesting.
Yes.
Any other questions? So time is coming.
One question for,
yes, please.
A question for Dr. Fennell, please. I'm Shreya Nanda from Medwire News. I'm just wondering, given the data for nivolumab and ipilimumab in the first-line setting, how does nivolumab in the second-line setting fit in? So, you know, putting the data in the context of the CheckMate 743 study.
Well, of course, the FDA has approved ipilimumab and nivolumab across the board in the first line. I think the answer to that may vary from region to region, actually. The data, of course, was positive overall, hazard ratio 0.74. But when you look at those subgroups, you know, the signal of activity was very much focused on the non-epithelioid subgroup. And that benefit was actually seen really as a consequence of poor sort of response to chemotherapy. So the chemotherapy really underperformed due to drug resistance. So when you look at the epithelioid group, there really wasn't a statistically different activity. And so when thinking about health economics and cost effectiveness in countries perhaps where this really matters, where it's a you know, something that needs to be considered perhaps because of state-funded healthcare, such as the UK, there are questions that may be asked around the order in which these treatments might be given, particularly in the epithelioid subset. And so that's one possibility for the future. The situation, however, is that there are a lot of patients out there now who have had first-line treatment, and getting access to some form of second-line therapy where there's evidence of efficacy is key. It's an area of unmet need and has been for ages. So in the UK, for example, we have provided access to nivolumab. It's perceived to be safer. I think our data bears that out compared to placebo, and particularly in the COVID-19 pandemic that we find ourselves, not having an immunosuppressive chemotherapy in the second line is considered to be a good thing. So we think that this randomized data could hopefully reinforce the use of nivolumab in patients in the relapse setting. But you know, historically, I think we've seen this with lung cancer, the sort of tide will push towards the use of immunotherapy in the first line. Whether it ends up being ipilimumab, nivolumab, or chemoimmunotherapy, just as we've seen in lung cancer, it's likely that immunotherapy will find its place in the frontline setting. But I think if at this moment thinking about the opportunity, it's for those who have had chemotherapy, and also the option, the debate may be that for patients with epithelioid mesothelioma, this could be an appropriate relapse or salvage strategy.
Great. Thank you very much.
I have one question. I know we're running over. This is Mark First, MD Edge, Hematology Oncology. Since there was no discussant for Dr. Bob Lee's presentation, could we have someone provide a comment on the code break 100 data, please?
So Dr. Fenner, you are the oncologist, so. No, so please comment on the code break study.
Oh, do you want my opinion on the code break?
Yeah.
It's a remarkable study, absolutely remarkable. I mean, I focus predominantly on mesothelioma, but you know, I've been around long enough to know that KRAS, speaking to people like Frank McCormick, this undruggability of KRAS has been something of a challenge for decades. And to see results like this from Dr. Lee is absolutely fabulous. And I am quite proud to be in the same meeting where this data was presented. I think there is an unmet need for KRAS. We screen for this routinely actually in our centre and many other centres in the UK, but without any purpose essentially. There's not a predictive value in doing KRAS until now. And I would like to think that based on this evidence, certainly in the UK, this will be a new stratified option for us. Yeah, so yeah, very excited about the data.
Yeah, so there will be a KRAS session tomorrow afternoon. So if you're interested, please come to the KRAS session. I'll be speaking about KRAS too. Okay, any other questions? Okay, thank you very much. Oh, yeah, yes, last question, please.
Please. I'm wondering if anyone could comment at all on the development of drugs. This is not something that was a topic of the press conference, but I've noticed that there are a number of drugs in development for multiple EGFR mutations that address multiple mutations. Is anybody following that might have a comment for me?
So multiple means compound mutations. I mean, some people has 2 mutations, but not 5, 6 multiple mutations in general. So are you mentioning the compound mutations?
Yes, there are some drugs that target multiple EGFR mutations, exon 20, but 18 and maybe 19. And
it is usually rare to have the 3 mutations. Some people may have the L858 or plus something, or exon 18 plus something, but at most 2 mutations. And the other situation is a resistance situation. So if the patient has a resistant disease, they may acquire the new mutation to resist the drugs. in that case, they may have the 2 or 3 mutations, but not multiple.
Okay.
I don't know, multiple is more than 4 or 5 like that, right? Multiple means.
Yes. Well, I was talking about 3, but.
Okay. Yeah.
That was, to me, was multiple.
That's usually rare, I think.
Okay. Thank you.
Okay, thank you again. Thank you very much for staying until the very end of this press conference. And please enjoy the rest of the conference, and please stay safe and healthy. Thank you very much.